Good morning, everyone, and welcome to the Sandbox. My name is Lisa Bonacci. I'm the Engagement Manager for the Sandbox Collaborative. This is the Research and Development Lab of Strategy and Innovation for Southern New Hampshire University. This morning, we're doing a Sandbox speaker series, Global Education and Global Health. So we're very excited to have two members of our faculty here this morning to speak to you. I'm going to have Dr. Denise Bizion come up and introduce our speakers.
Thanks, Lisa. So before I introduce them, I want to thank the team, Dr. Jan Wyatt, who is the Senior Executive Director for Nursing, Health Professions, Social Sciences, and Education, Vice President Jen Brady, Heather Marr, and Lisa Bonacci for putting this together. It was a pleasure working with all of you. So first, I'd like to introduce Dr. Tiona Jenkins. She's the Regional Director of the Clinton Foundation Health Matters Initiative at the Clinton Foundation. And in this role, she works under the portfolio of President Bill Clinton, who was the 42nd President of the United States. She's responsible for leading the collaborative efforts with key industry, corporate, governmental, and non-governmental stakeholders to develop and implement a blueprint for action focused on healthcare needs, reducing healthcare costs, and improving health and wellness indicators in targeted communities. Additionally, Dr. Jenkins has supported the launch of community health transformation initiatives in 6 U.S. regions aimed at closing health disparity gaps and improving health outcomes through cross-sectional system change. Before joining the Clinton Foundation, Dr. Jenkins worked with the Robert Wood Johnson Foundation, where she led efforts that address pressing needs around equity, education, healthcare access, healthy eating, and physical activity for state and local municipalities in 13 targeted states across the United States. Dr. Jenkins earned her doctorate of philosophy and public policy from the University of Arkansas, a master's of public health from the University of Arkansas for Medical Sciences, and a Bachelor of Science degree from Philander Smith College. I also would love to introduce Sarah McCool, who is a dedicated global health practitioner. She's worked in a variety of consultancy and leadership roles in global health and development. She has consulted for the International Breast Cancer Research Foundation in Bangladesh, held the position of executive director of nonprofit that provides health care to the rural population of Southwest Haiti, and consulted for a Fortune 500 company on how to reduce tuberculosis burden among garment factory workers in South Asia. She also has her own small nonprofit organization that supports health and education projects in developing countries. In partnership with her Haitian colleagues, she's recently started a new project that will help bring sanitation and hygiene to female prisoners in Haiti. She's currently a PhD student in global health at Arizona State University. She also has her Master's of Public Health in Healthcare Administration and continues to teach undergraduate and graduate courses in global health. So I welcome both of you, and I believe Tiona is on? Yes, wonderful.
Good morning, everyone. I first want to take the opportunity and thank you all for the invitation to be here today. It's my first time in New Hampshire, so really excited about the cold weather. Not too cold in Arkansas, but it's very pleasant, very beautiful. Got to see a couple of things on Elm Street. That's about as much time as I've had thus far, but really do appreciate the invitation and being here today to share my perspective on global public health and some of the things that have been done around the country, domestically and globally. I added in global public health and innovation to my discussion today because in my experiences and at the various foundations that I've worked for and worked with, we always focus on innovation, application, and implementation when it comes to formulating solutions. So it's just not identifying the public health problem, but then also coming up with those solutions to address those public health issues. Okay, so through my bio, I'm sure you all heard where I work, which is wonderful and fine. But I also have to add this disclaimer that the opinions expressed in this presentation and on the following slides are solely those of myself. These slides are a collective observation of the presenters' experiences as a public health practitioner and as an academic professional, just to get that little housekeeping out of the way. So, as I've worked within public health, and specifically in my career, I get a lot of conversations around what is a public health policy practitioner? What do you do every day? So I like to deem myself as the Olivia Pope of public health. I work I know, right? I'm good. I work behind the scenes quite a bit on systemic policy change, not necessarily in the forefront. So I wouldn't be working on health education or anything like that, but definitely convening stakeholders of all diverse sorts around the table to have conversations around what the public health problem is and how can we drive solutions to do that. So in any given day, I can have conversations and go in negotiations and brokering relationships with CEOs of Fortune 500 companies, trying to get their investment or corporate social responsibility and why they should invest in public health. I could also have conversations with individuals who are invested in communities, right? And they want to see some changes in their communities, or NGOs or nonprofit organizations. So anyone who has a vested interest in changing public health outcomes, having those conversations and getting us all on the same page. Whomever I'm talking to, or in any capacity that I'm speaking with individuals, I always put a face for those conversations, because so many times those of us who do work behind the scenes and work in public policy, we can sometimes get disconnected. So it's very important to understand that as we make these public policy changes, as we build partnerships around collective action for communities, that individuals will be impacted, which is why I have this first slide here, because the decisions that we make actually impacts individuals, their communities, whether their health outcomes are favorable or not. It also impacts their systems changes, whether individuals are able to have access to the healthcare resources that they need. And so I like to say we're one world, and we're all interrelated and connected. There are a couple of frameworks that personally that we work from, and personally that I work from. I'm sure as many of you who are familiar with the framework of health is very equivalent to the social determinants of health. What we believe is that in order for healthcare outcomes to change, we must first focus on policy and programs, and also those healthcare outcomes. Not to say that individual behaviors are not important, because they most certainly are, but for things to be sustainable and changeable, we must look at policy and programs and how those things affect our healthcare factors as well as healthcare outcomes. So within social determinants of health, we like to look at things that are outside of clinical care. So it doesn't necessarily just depend upon whether somebody has access to a physician or a clinician, or access to prescription, their prescriptions or their medication. We also look at the clinical care environments, the physical environment, their health behaviors, and the social and economic factors that are a result of that. So really important to, as we try to address these healthcare disparities and inequities, looking at family and social support, education, employment, income, and community safety, because all of those things play a role in whether a community is healthy or not. So we focus quite a bit around holistic health, right? And making sure that individuals and those disparities gaps are closed within those areas too, and not just solely focusing on individual health care. Again, this is another slide that kind of gives you a little bit more information around what the social determinants of health are. So again, economic stability, looking at employment, income, expenses, debt, medical bills. Looking at someone's neighborhood and physical environment, how does housing and transportation and safety impact healthcare outcomes? If an individual lives within a community where they cannot readily access those things that deem a community healthy, then they're not going to have favorable healthcare outcomes. We also look at education, literacy levels, language, early childhood education. When we think about food, we look at hunger. We also look at access to healthy food options as well. Community and social context, looking at how these social support services integrate with one another, and community engagement. We also focus quite a bit on equity and discrimination and its role within the healthcare system and in public health. And here within the healthcare system, looking at all of these factors here, these social determinants of health determine if a community is healthy or not just simply whether they have access to a physician or if they have prescriptions. This is a nice little diagram here that I use quite a bit when having conversations with strategic partners or stakeholders who don't necessarily work within the public health sphere, and really trying to translate to them and relate to them the difference between equality and equity. Of course, both are very important, and the term that we've been using for quite some time is equality. However, now we're merging into more of equity. And you can see here from this diagram, with equality, everybody has the same resources, right? The same box. But over in equity, we provide the needed resources for those who need it the most, right? So this gentleman right here definitely has the height that's needed here and doesn't necessarily need a box. But this little guy over here, or this little girl over here, definitely needs more resources. So our policies and programs need to be targeted towards those individuals and towards those communities that need additional resources. And we should be okay with that. So in researching it's for today, definitely want to talk about the top global health issues for 2016. Not going to necessarily go over all those because we only have 15 minutes. But the top here, and you can read these for yourself: Ebola, mental health for trauma survivors, a reversal in health worker shortage, air pollution, emerging and waning health threats such as polio and HIV, climate change, healthcare systems and chronic disease, politics, and power shifts that's extremely important when it comes to our healthcare systems and how we deal with public health as a whole. Today, I'll only hit on a few of these topics. Specifically, I'll discuss the public health issue and provide an innovation that has been done, or one of the many innovations that have been done around a reversal in healthcare workers shortage, healthcare systems and chronic disease, and one that is not listed here but is of extreme importance is the technology and digital divide and its place within the healthcare system. So when we think about chronic disease and obesity, that's definitely an emerging public health issue that has not necessarily changed that much when it comes to healthcare outcomes and favorable healthcare outcomes. The data here continues to worsen. So worldwide, obesity has more than doubled since 1980. In 2014, more than 1.9 billion adults 18 years and older were overweight. Of those, over 600 million were obese. 39% of adults aged 18 and over were overweight in 2014, and 13% were obese. Most of the world's population live in countries where overweight and obesity kills more people than underweight. 41 million children under the age of 5 were overweight or obese in 2014, and we know that obesity is preventable. So with that being said, again, obesity is extremely important. And in my capacity as a public health practitioner, and specifically focusing on policy and systemic change, we want to look at innovative solutions on how we can address obesity and any chronic disease, and not necessarily the traditional mechanisms or methods in which we've done that. So having an opportunity to pull together many, many different partners, because obesity impacts employers, it impacts you as an individual, it impacts your community, healthcare costs, et cetera. So you definitely need individuals around the table with different backgrounds, resources, and we all want individuals to have a mindset or a culture of health. Public health doesn't necessarily just belong to public health practitioners. We want everybody to emerge into public health and to understand its place within their respective industry. So we're going to go to the first video, and one second. The first video is addressing obesity, a chronic disease, and this was a systems innovation project that we're still currently working on in my current role with the foundation, but bringing individuals together around what individuals are served when we look at our food industry, because we want to change the perception of what organizations feel that they can do and how they don't necessarily have to stick within the traditions of what is served in the food industry.
McDonald's started with a mission to help families increase access to fruits and vegetables, and formed a partnership with the Alliance for a Healthier Generation on 5 commitments impacting 20 global markets by 2020. We started with 2 major markets, our largest, the US, and Italy, and now have some exciting preliminary progress to share. By focusing our first commitment on featuring only water, milk, and juice as the beverages in Happy Meals, we saw a 9 percentage point increase in milk and juice selections in the first 11 months in the US. This contributed to 21 million more low-fat and fat-free milk jugs and apple juice boxes being selected for Happy Meals and a la carte options in the U.S. After removing soda listings from Happy Meal menus in the U.S., soda selections fell by 8%. We dedicated our second commitment to offering alternatives to fries in value meals, like side salads and other produce options. And now 96% of McDonald's Italy restaurants and 83% of McDonald's US restaurants offer side salads and other produce options. Our third commitment was designed to generate excitement for fruit, vegetables, and dairy with Happy Meals. Fruit sides have steadily increased in Italy from 2013 to 2014. Meanwhile, McDonald's USA has served the following in Happy Meals and a la carte: 38 million Cuties Clementines, 161 million tubes of Go-Gurt low-fat strawberry yogurt, and 380 million bags of apple slices. Commitment 4 focuses on using our Happy Meal boxes to deliver well-being messages. And both the US and Italy have exceeded the 4-box minimum requirement. And lastly, our 5th commitment focuses on including well-being messages in 100% of kids' advertising, something in which the US and Italy are already more than 99% compliant. There's more to do, but we're off to a great start. Thanks for watching.
So this video kind of gives you a glimpse into what some of those conversations around healthy meal options are and what that looks like systemically, right? So you now currently go to McDonald's and the language has changed, right? So it's more of different options that are healthier options, not necessarily your upsized fries anymore, unless you ask for them. Of course, you can, still get them. But the option now is to have more healthier options for both adults and for children. This was a historic agreement that was done with the McDonald's Corporation, and individuals have really been uptaking those healthier options, and other big food industries are now taking suit and following suit with some of those same things. So it's about changing the environment. And this is systemic policy change. It doesn't happen overnight. So it's not like a grant that you give to a project for 6 months or a year, 2 years. This has been in the work and conversations since 2012, 2013. So it takes time to change people's thought processes, what they do internally with their organizations, why that's acceptable, et cetera. So I'm glad to be a part of that team and work on that. The next area that I want to address is equity and looking at the digital divide in our healthcare systems. And about 70% of complex medical devices sit inoperable at their destinations in developing countries. Most basic devices don't reach developing country populations in adequate numbers, and lack of basic infrastructure, distribution channels, trained personnel, and engineered systems required for utilizing these devices appropriately. When you think about the digital divide, some folks are, puzzled when we discuss this, because they're thinking, what does this have to do within the healthcare system? What does this have to do within the public health space? It's extremely important in the public health space when you think about how we can address communities, populations, both domestically and globally, because everybody now has some form of technology. Well, not everybody, of course, in developing countries, there's still challenges there, but have some form of technology in their hands, right? So we are now live streaming here, right? We're sitting participating in an innovative, collaborative space to think about those ideas on how we can integrate technology and close the disparities gap. So one innovation that has proven to be extremely vital and has shown some progress in moving the needle is working within healthcare systems and really looking at the diabetes population and working on diabetes populations management and having individuals that suffer from or have those chronic diseases to be able to use their cell phones and their smartphones to have communications and conversations with their physicians or their clinicians, and not necessarily having to go into a clinic or a hospital. Why is that important? Because individuals who are low income, et cetera, or who may have challenges, may not always have transportation. So that should not be the reason why individuals are not able to get the healthcare services that they need. Another area in equity that we also address is the digital divide of women and girls. About 20 million fewer women have internet access than men in the developing world. With more access to technology, women can advance their economic participation, digital citizenship, access to jobs, and healthcare, and more. So we see that technology is thoroughly integrated within the healthcare system and in other areas that we don't traditionally think about. When women in the developing world get online, there's a 30% increase in connection to earn additional income, 45% use for searches and jobs, and 80% to improve their education. So definitely the digital divide needs to not be the digital divide. We need to address those equity issues, specifically around disparities, communities that don't necessarily have the resources, as well as women and girls. And this is an innovation video around some of those things that I was speaking about.
In 2015, countries worldwide adopted a set of goals to reduce poverty, improve health, protect the planet, and increase shared prosperity. Achieving gender equality is critical to accomplishing these goals. The rate of women who die in childbearing has dropped by more than 40% since 1995, but progress is uneven. Part of the success can be attributed to advancements in education. Girls' access to primary school has improved considerably. Yet gaps persist. Less than half of girls in South Asia, and fewer than 1 in 3 girls in sub-Saharan Africa are enrolled in secondary school. And in regions where the gap has closed, women pursue STEM fields at disproportionately low rates. The percentage of those living on less than $1.25 a day has more than halved. Yet discriminatory laws and practices make it difficult for women to earn incomes and gain access to financial resources. Still, expanding women's role in the labor force would make measurable economic impacts worldwide. If female farmers had the same access to productive resources as men, agricultural outputs could rise high enough to pull up to 150 million people out of hunger. We've made progress, but by strengthening partnerships between governments, businesses, and communities, we can realize the full participation of girls and women to achieve our goals together.
And my last and final slide is addressing the healthcare workforce, which I think is part of the reason why SNU has really focused on this area of developing global public health leaders. Currently, we have a global shortage of 7.2 million health workers in the field, and that's really looking at individuals that could contribute to the field but don't necessarily do it now. So the community health workers, our CHWs, both globally and domestically, should be integrated more into the healthcare system, integrating technology and having more of a health team approach and not an individual one-on-one approach with clinicians. Under the Sustainable Development Goals, which were previously mentioned in the video, or SDG, a strategy to build a more stronger and equitable workforce is needed. Thank you so much.
Now Sarah McCool, and then we'll have a short question and answer period afterwards.
Okay. Hi, everyone. My name's Sarah McCool, and thank you for having me here today. So before I start, could I have you bring up the video? Okay, so I'm going to show a short video first. And when we talk about the issues in global health today, we talk in these large numbers, 1 billion people in poverty and multi-million, hundreds of millions of people suffer from heart disease. But it can be really hard for us to actually understand what that looks like. And so this video I like to show gives us an idea of what some of our world issues would look like if we took the world, made it into a village of 100 people, what that would look like, what those issues would look like. It just helps us better understand what we're looking at. So go ahead. Hopefully, or I'm sure some of you saw a couple surprises in that video, right? Things that you thought you weren't aware of. Okay, so I'll start now and I'll define, oh, do I have the clicker? No. That would help. Okay, so what we saw in that video is all of those things are actually global health issues, okay? All of them. When we talk about global health, there's a lot of different definitions, okay? So Copland definition, an area for study, research, and practice that places a priority on improving health and achieving health equity for all people worldwide. So that's an important definition, but I also want to emphasize some other aspects of global health that are important to know. So first is global health focuses on health issues that transcend borders, okay? So they are issues that cannot be contained within the national borders of a country. Most of us think of communicable diseases when we think of that, things like Ebola, right, and HIV. But it's also, we need to understand that global health views health as a basic human right. So it's something that all people should have access to. We don't view health as a privilege. We do focus generally on vulnerable populations because those are the people that need the most health resources. And finally, the most important part of this global health definition that I want people to remember is that global health refers to the scope of the problem and not the location, okay? All right, so I'm going to detail what I think are the three biggest global health issues today. And the first is financing. So who's going to pay for these global health systems and improvement? This is a graph that shows official development assistance between the years of 2000 and 2014. And the good news here is that we have seen that health financing has generally increased quite substantially, particularly leading up to the year, or starting in 2010. The bad news, however, is that we've seen since 2010 that this has remained pretty stagnant, okay? We need financing, we need funding in order to improve global health. It changes depending on the administration. The current the incoming administration in the United States, it remains to be seen what type of outlook and policy that administration is going to have for development assistance and global health issues. Generally, it tends to decrease in Republican administrations, but that doesn't always hold true. George W. Bush became a huge champion of HIV when he created the PEPFAR initiative, right? And no one actually anticipated that. So it remains to be seen. However, we do need financing. The second biggest global health issue is poverty. If you remember nothing else that I tell you today, I want you to remember this. Poverty is the single best predictor of ill health. I will repeat it again. Poverty is the single best predictor of ill health. If we could, quote unquote, fix poverty, we could fix a lot of health issues. This is actually a picture from Haiti, which is where I've done most of my work. All right, the good news about poverty is we have seen the number of people living in what's considered extreme poverty, labeled as $1.25 per day or less, substantially decrease since the year 1990. So in 2015, we had 836 million living in extreme poverty compared to almost 2 billion in the year 1990. All right. Something I need to point out about this, however, is that this measure of poverty is very one-dimensional. All right. So once this assumes a poverty uses what's called the poverty head count ratio. So essentially, if you are living on $1.25 per day or less, you are considered in the poverty head count. Once you are making more than $1.25 per day on average, you are no longer included in the head count. So if someone is making $1.30 a day, they're no longer included in that poverty head count ratio. However, the likelihood of someone experiencing drastically better living conditions is probably quite low. All right. So one of the great things that we are focusing now on when we look at poverty is we are looking at a more multidimensional picture of poverty, and the Sustainable Development Goals, which Tiana mentioned, is looking at this more multidimensional picture of poverty. So we're looking at things like land ownership rights, access to credit, gender equality. Okay. All right. And then the third biggest issue, probably to no one's surprise, is the refugee internally displaced persons and stateless persons crisis that we are seeing. So in 2015, we had over 65 million people who were forcibly displaced worldwide. The number of forcibly displaced people has more than doubled in the past 20 years. So we are not seeing the situation improve. We are actually seeing it get worse. One of the issues, particularly with refugee IDP or refugee health, is that when they go to some of these countries, other countries may be ill-equipped to actually. They already have overwhelmed health systems, and those countries don't necessarily have the resources to assist the refugees with their specialized health needs. And that's one thing I do want to point out, is that refugees do have specialized health needs. There was a recent study that was done in Sweden that found that refugees are actually at greater risk for developing schizophrenia. All right. So, and that's believed to be linked to the trauma that they've experienced. So how can we actually provide specialized health services that not only address what they need in terms of mental health and physical health, but that also understands that they are going to need probably a lot more services that are culturally competent services that places may or may not be able to provide. And I included this quote. This is one of my favorite quotes. You have to understand, no one puts their children in a boat unless the water is safer than the land. All right, so finally, how is Southern New Hampshire University preparing future global health practitioners? Well, first, they are preparing critical thinkers. So one of the great things that SNU does is that it provides assignments, or it gives assignments to students that mirror actual real-world tasks. So they don't actually ask you to just write a paper. Okay, they want to give you a task that is going to mirror what people are going to be doing in their profession, in the field. They're also trying to create innovative solutions, which Tiana talked about innovative solutions as well. Okay, SNU is really great at being innovative, and in this capacity, they're also training students to be innovative thinkers. Also, particularly in the global health curriculum that is being taught, is this idea of cultural competence, which is particularly important when you're talking about a refugee population, but not just a refugee population, a population particularly in a country like the United States that is this melting pot. So cultural competence, I want to emphasize, is not something that can be taught in a classroom and you can check a box and say, I'm culturally competent. It's fluid. It changes depending on the situation. It is very context specific. So I am culturally competent in Haiti. I am not culturally competent in Guyana. Okay, you build cultural competence through experiences. However, what we can do and what we want to do in the classroom environment is equip students with the tools to be able to think critically, analyze, and ask the right questions so that they can become culturally competent in a situation that they are in. And then finally, the last thing that SNU is doing, particularly in their healthcare professions and in the global health concentration curriculum, is this idea of this holistic view of health. So health is not merely the absence of sickness or disease. It is dependent on a whole host of things, your access to education, transportation, healthy food. All of these things impact your health, okay? And that's the end of my presentation. Thank you.
So you may want to both be up there and
Oh, yeah.
you can,
Questions?
and questions from the audience. Either, I don't know if we can have lights on there so that you can see. I'm sure you all have many questions. And we have,
Once we did so well,
healthcare
then
providers, and we
they have no questions.
Right.
Go ahead.
Yeah.
So I know this is somewhat related, but you talked a lot about a digital divide, and I'm just wondering, it's an interesting intersection between a lot of these health-related issues and digital technology. We'd love to know, like, what is the digital divide, and how does that sort of fit into this?
So you're asking what is the definition of digital divide?
Yeah, and I just think there's something, I just don't want to make the connection between the two.
Yeah, no problem. So many definitions of the digital divide, depending on whom you're speaking with. And my experience and context of the digital divide are individuals who are without any technology capabilities, right? So they may not have a cell phone or a laptop or a smartphone. And so as we understand that the world is transforming and evolving, a lot of things are playing into technology. And so that's definitely a digital divide there when individuals do not have the resources at all. Another definition of that would be individuals who are not digital literate. So you may have those capabilities to have your access to various things, but may not know how to operate those things effectively as well. Another definition for digital divide, and I did not mention it in the slides because I was trying to be cognizant of time, is that quite a bit of our technology and mobile devices are made in developing countries. However, those developing countries do not have access to those digital devices. And so that in itself is a challenge and an issue and a policy issue as well. And those mobile devices are thus, exported out for all of us, but developing countries do not have access to those things for many, many different reasons.
Can you talk louder? And can you repeat the questions? So that
Oh, I'm so sorry. I didn't do that.
I want to put that on record. So you mentioned 6 to 8 pretty major crisis level initiatives for 2016. And when I think of global health, I think, where do you start? So global health to be supported through beyond the United States, do you find that the global agenda is generally the same and that the countries that we're trying to work with to truly make a difference and improve globally are on the same page?
I would say overwhelmingly yes. So one of the great things about the Sustainable Development Goals that Tiana had mentioned, which are a replacement to the Millennium Development Goals, which are a set of 8 time-bound goals set to eradicate poverty and improve health and well-being worldwide. when the Sustainable Development Goals took the place of the MDGs, which expired in 2015, and the Sustainable Development Goals go from 2015 to 2030. The MDGs were developed had a very top-down approach. The SDGs were a very participatory process. So they actually flew and met with stakeholders in over 100 countries face-to-face and talked with them about what are the biggest issues that you are facing. So yes, overwhelmingly, I would say the world as a whole is on the same page.
And just to add a little bit about that is we recently was working with the Council on Foundation, which works both domestically and globally. And so to your point, it really is a community-based investment and convening of partners on the ground and working in the field to get their input on what should be the pressing issues within that particular community. So very different model than from before, very different. And I think it's going to be more effective and impactful.
What do you think that we could do at Southern New Hampshire University help our female population make sure they get to graduation in our healthcare programs? So can everything
Sure. I don't know if I have an answer, but no, I'm just saying. What could Southern New Hampshire University do to ensure that females graduate from the program?
Right.
Okay.
Beyond what we're already doing.
Beyond what you're already doing, right? I would definitely say it's extremely important to have conversations like this. And to raise those questions so that we can put it out on the table, especially if there is a gap there of it not being a strong representation or representative of females in the program and graduating in the program. So definitely having these conversations and bringing that question up. Mentors worked really, really well for me. We were having conversations over dinner and this morning early about just the impact of having advisors and mentors to kind of guide you through the process, because as a graduate student, I definitely had questions about my next steps and what I would do after I graduated from and with my graduate degree, and even just within the courses in itself, having professors that are females is extremely important, and having those professors not only having professors or instructors, but having them in higher ranking levels in administration too. So those things I would say would definitely help, and continue to do the things around critical thinking that Sarah had mentioned as well.
Yeah. And I will just add one more thing to that. Beyond the support, the fantastic support that Southern New Hampshire University already provides to students, I think that for me personally, as a global health practitioner and as a student, et cetera, seeing how much has been done in the global health and even the health professions arena already is inspiring, but then you see how much work there still is left to do, right? And so that hopefully can help provide some push to people that are in the health professions program to give them some inspiration on how they can make a difference in the world and in their own communities.
I just wanted to share some observation of, as you were moving through this, and I was thinking about the programs and the talent that we have at Southern New Hampshire University with regards to developing and getting expertise from practitioners in the field that is contemporary expectations and competency requirements. It's amazing that, to me, that public health really does bridge our counseling, our psychology, our STEM, our technology, our nursing programs. So if done well, and if we can broaden the scope and offering, there's so much more work, I think, that this will translate into and impact and value for students.
Right.
And I think that we're very fortunate in that way, because we do have such a strong portfolio foundation of other programs that really do intertwine with the education that they're going to need, the experiences, the insight beyond public health, and all of those areas that really feed up into it. So just as you were both of you moving through your presentations, it was astounding how much I'm thinking public health as one area, but it really bridges so many.
It's a lot. Yeah. Yep.
It's definitely.
It's almost overwhelming. Well, it is overwhelming.
Yeah.
It is.
Yeah, and how we do capture that, at least in the nursing health professions. And this is the best opportunity to
Definitely.
You said it so much more succinctly. Will, do you have a question?
So I have a question, and this is just because I don't know. I'm very interested in disability rights and disability sort of issues around this, and I'm wondering if the sort of global health approach, public health approach, however you want to define that, is really cognizant of that. Is that part of the narrative of what we're talking about when we talk about global health initiatives and things like that? Because I'm really curious, particularly when it comes to sort of hidden disabilities and sort of neurodivergent thinking and things like that.
I would say that there is some recognition, particularly in some circles. There is much more of a movement to recognize mental health disabilities worldwide. However, there is still so much work that needs to be done, particularly surrounding cultural stigmas and discrimination. But in terms of other disabilities, like I said, I think it is recognized in some circles, but I will say that there is a lot more work that needs to be done in terms of recognizing disability rights in global and public health. Yeah. Did you want to?
Yeah, I just wanted to add a little bit to that. Definitely an agreement around that. Circles and conversations are happening. More needs to be done. There's also disparities and inequity in pay when it comes to disabilities as well, which needs far more attention too.
So thinking about the work that you've done in Haiti, when you think about all the outreach and aid that's gone to Haiti, have you seen any actual improvement or any outcomes that are positive?
That is a fantastic question. Oh, yes. Given my work in Haiti and all of the aid that has flowed into Haiti, has there been any significant or noticeable improvement in outcomes? I will say, yes, there has been some improvement in health outcomes, particularly in like the past 20 years. We've seen an increase in life expectancy. We've seen decrease in some of the communicable disease prevalence. However, if you aren't aware, after the earthquake, almost $10 billion flowed into Haiti. And I will say less than 1% of that went to the government. So a lot of people like to say, well, the government's corrupt. It is, but they don't get very much of the aid money. It's just a fact. Most of the NGOs get the aid money. And was it spent appropriately? Probably not. There's a lot more that needs to be done. Haiti is known as the Republic of NGOs. It has the highest number of NGOs per capita in the world, second to India. And people kind of work in their own silos. And it's timely you asked that question. My dissertation actually studies collective action among NGOs working in maternal and child health in Haiti. And I've found that there is some cooperation that's occurring between NGOs, but everyone acknowledges it's not enough. More needs to be done, and we need to figure out how to make this happen because collective action is one of the best ways to achieve common goals, right? Yeah. So, great question. Thank you. Our day is just starting.
We're actually very close to our end time. And any other burning questions you have to ask right now? Okay. So thank you so much.
Thank you.